Hey guys, welcome to Chapter 10, Topic 1. If you thought we learned a lot in Chapter 9, well, buckle your belts because we are going to pile it on in Chapter 10. And as I've told you before, these are really the core concepts that we expect you guys as future healthcare professionals to take away from this introduction to microbiology course because these are the things you're going to be using a lot more in your career. In this first section, we're going to talk about how antimicrobials work. And we generally talk about antimicrobials, we say antibiotics, but that's not always the case. So that's why we use the term antimicrobials, because it's a little bit more of a broader term. So why is this topic important? Just as I said, besides controlling microbes from growing in clinical settings, we also want to treat infections once people have them. So it's really important as a healthcare professional that you understand what types of antimicrobials there are and how they work. All right, so let's get started. Principles of antimicrobial therapy. It's hard for us to believe that the medications that you and I can take now if we get an infection weren't around 100 years ago. It wasn't until 1930 that the first antimicrobials were developed. So it's really amazing how much they've revolutionized the way that we have been able to treat infections. And in fact, without penicillin, there would have been a lot more deaths in World War II than there actually were. So the goal of antimicrobial therapy is to administer a drug to an infected patient and have it destroy the microbes without harming the patient further. Now this isn't always a perfect situation, but it is something that we aim for. Now a term you're going to see throughout this topic and throughout this chapter is called chemotherapy. And I know that we always think of chemotherapy as cancer treatment. Well, that's not quite how it works. Chemotherapy is actually a much broader term. It's the term used to describe any kind of chemicals used to treat a disease or a disorder. So that's chemotherapy, using drugs. So when you see that, try to not think about cancer necessarily, but just think in general terms. Now, when we go to develop these drugs, there's a lot of different characteristics we look for, and you can see them on the slide here. The first one is that it's selectively toxic, meaning that it targets the microbe, but it leaves the host cells alone. As I said, that's not always possible. It depends on how bad the infection is, depends on what the microbe is, but that's our main goal. That means it's easier to treat prokaryotic infections than it is to treat eukaryotic infections, as you can imagine, because prokaryotic cells have a lot more differences than eukaryotic cells from ours. It's a lot more difficult to treat a helminth or a fungi infection than it is to treat a streptococcus infection with drugs. And so you can look through the rest of this list, and I'm not going to sit here and read them to you, but that's the main one that I wanted you to focus on. But look through them all and be familiar with these characteristics. This is a chapter where there's going to be a lot of terms, a lot of things you got to learn. All right, so types of chemotherapy. As we just talked about, chemotherapy is a chemical used to treat, relieve, or prophylaxis a disease. Okay, it's as simple as that. And so there's a lot of things that we look for in chemotherapy treatments. We have three main criteria when we go to select what kind of drug we're going to use. So what is the microbe that's causing the disease? Or do we know what kind of class it's in, or at least do we know if it's a viral infection versus a bacterial infection? Then we want to know how sensitive it is to drugs. And this can be done in either the hospital setting or a best guess as to what it is, because it's not always the case that we can find the agent immediately. And then the last thing is, what is the patient's health status? Obviously, if you have a minor cough, things are going to be able to be taken a lot slower and made sure that we do the right drugs than if you are in critical care at the hospital. So it's really important that you take that into account as well. So you see over here that all the different groups of chemotherapies that exist. And I want you to take a look through them and get familiar with all these. But two terms I want to get on the table now, because it's going to play a role later, is narrow spectrum and broad spectrum. Now we usually refer to these as narrow spectrum or broad spectrum antibiotics, but what we're looking for is narrow spectrum or broad spectrum in general action, and they could be any of the actions we see above. Now, narrow spectrum means that it affects a very specific type of bacteria. So as you can see from the example on the chart, it affects only gram-positive bacteria. So it can be a very narrow window, whereas broad spectrum may be effective against positive and negatives. So this is kind of a shotgun versus the sniper approach. A shotgun approach is one that's great when we don't know what's going on and we just need to clear it up, whatever it is. But what happens with that broad spectrum is we also clear up all the normal microbiota. So a person could potentially even become sicker than they are before because we've destroyed the microbiota and didn't manage to hit the agents causing the disease. Narrow spectrum, on the other hand, will leave the microbiota alone generally if we choose the correct narrow spectrum, but it will also potentially miss the agent. So that's where that balancing act comes from. So those are things that are really important to take into consideration when selecting drugs for prescription. So the next thing that's important is identifying the infectious agent. As we talked about, there are three things that every practitioner should pay attention to. What is the agent, how susceptible it is to drugs, and how is the patient handling it? So the first thing is identifying the agents. And this is something that all of you should be almost experts in at this point because we've been dragging you through these assays in lab all term. And so that's where you would see these things. The things that you guys are doing are stuff that is done in clinical laboratories. So we'll take samples from blood, sputum, stool, swabs, or a variety of them, and sometimes more than one, depending on what's going on, to be analyzed in the laboratory to have the identity of the unknown agent that is causing the disease identified. But as you are well aware, most of these processes take several days to weeks to identify them. So practitioners may actually be in treating before they know the infectious agent. And this is actually somewhat of a balance with antimicrobials. And we'll talk about that in the third topic, what this means. But that's how we identify those agents. So the stuff that you're doing in lab is exactly how they do it in the clinical lab, just with a little bit of a spin on it for clinical needs. So once you've got your bug, it's time to figure out how susceptible it is to different types of drugs. So we use a couple different assays for that, and this really only works on bacterial infections, not fungal or protozoan. So it's important to be aware of that. And if a patient is allergic to something, then you don't need to necessarily do this, because if you know that your erythromycin is probably going to be your best bet and they're allergic to it, then you know you need to go to the second best choice. So it's one of those things, this is not always done, it just depends. So there's two main assays, and you will have performed both of them in lab. Either, if you haven't already, you will shortly. The first is the Kirby-Bauer, which is what you can see here on this slide. So what we do is we take a sample of the isolated microbe and plate it on an agar plate such that there's a nice heavy field of growth. So there's growth of this microbe everywhere. We then, after we plate it, we then put these discs that have been soaked in antibiotic on the plate spread out. And we allow it to incubate. And then what you get is these zones of inhibition, this area where the microbe has not grown. And that's because the antibiotic has prevented that growth. And so it's one important aspect of this, though, is you look at it right away and you think, oh, the top disc. The top disc is the right answer. It's got the biggest range of inhibition. But that's not always the case. It just depends on each antibiotic. Each antibiotic has a resistance and a susceptible range. And so some of them have really big ranges before they become susceptible, such as 30 millimeters, and some of them have very small. So you actually have to use an interpretation chart to read these. You can't just go off of eyesight on them. So that's important to pay attention to. The second type of drug susceptibility is called the tube dilution assay, and it helps determine the MIC, or the minimal infectious control. Now, this is what we the minimum inhibitory concentration. And so what this does is it takes a series of tubes and it puts the same amount of microbes in there with varying dilutions of various antibiotics. And what this allows us to see is what tube has prevented the growth, and that is the minimum inhibitory concentration. Now, the reason why we don't see this one as often, or we don't talk about it as often, is because it's a lot more setup. But it is a lot more qualitative and it provides us a lot more information than the Kirby-Bauer. So it's one of those hands-off. Is do you want a quick and easy that doesn't take up much space, or do you want to take up the time to find and supplies to find that exact concentration? So they're both good, they just have different uses for them. And so it just depends, especially if you're talking about a run-of-the-mill infection. A Kirby-Bauer might be the easier answer, but if you're hunting up an infection that none of the antibiotics you've tried so far have worked, that might be the way to go. So that's the balancing act of determining drug susceptibility. So now we need to talk about how we choose a drug. So we know what drugs are susceptible to, we have our list, but now it's time for us to figure out which one to use. Now there's a couple different aspects of how we choose these drugs. The first is the therapeutic index. So what this means is that every drug has a level of which it's therapeutic and a level at which it's toxic. And this means that if you take 5 pills, it might kill you, but you take 2 pills and you're going to be fine and your ailments will be treated. The closer those numbers are together, the more dangerous it is. So if we were to tell you that the aspirin you have at home, you take 1 pill, it's going to treat your headache, 2 pills and you're going to die, that's really dangerous, right? Because what happens if you forget if you've taken one and you take another one? So that's why a therapeutic index is really important. And generally the ones over the counter, and not your aspirin by no means is this way. It was just an example. Have high therapeutic indexes. So it takes a lot between therapeutic dose and toxicity. But there's a lot in the hospital that are very close. And so we try to use safer choices if we can, but once again, it comes back to what's going on with the patient. We also have to consider a few other things. Where's the site of infection? If it's a brain infection or in other places that are blocked by blood-brain barriers, we're going to have to pick specific drugs that can cross those, because not very many drugs can cross the blood-brain barrier. We also have to consider patients. Do they have allergies? Do they have organ failure? What's going on with them? So it's really important that we consider a lot of aspects. It's not as simple as, doing the Curry Bauer and deciding on your pill. So there's a lot of different aspects that go into that. So I want you to really think about that and be cognizant of how important drug selection can be. This is why there's a whole profession called pharmacy, because these are the people who help contribute to that decision. So now let's talk about how these drugs actually work. And here's our mechanism of drug action. Now, as you remember from chapter 9, there were a few sites of microbial control drug action, of chemical control drug action, chemical control action. And you can see them here on this slide. Is very similar in the same aspect, which makes sense, right? Because we want to target the same ideas. So you can see that we have a variety of different targets here. And remember, even more so in antimicrobials, in drugs, is it important that we target things that are different from eukaryotic cells. Because with chemicals, we can wear gloves, we can wear masks, we can prevent the touching of them. With drugs, we're putting them into somebody, so they have to be able to not kill that person in the process. So you can see a couple different options here on the list of where they target, and I'm not going to go through all these right now because you can just read them too. But one of the things I want to point out is that ribosome. Remember, we have ribosomes too, and they look really similar, but they are just different enough that we can target the bacterial ribosomes instead of ours. So that's what's important about that. So take a moment if you need to pause this lecture and look through these different mechanisms of drug action. So now that we've talked about the targets, now we can talk about some drug examples. And I'm not going to expect you to memorize this chart or anything, but let's just look at one key example. In drugs that target the cell wall, there's the class of penicillins. And what happened is after we discovered the first penicillin, we went about making analogs of it. We wanted to change it around because penicillin was very specific. It could only target a handful of things. But when we modified them, it became a lot broader of a class of drugs. So it's a lot easier for us to use it for a variety of things. So you can see that here. You can see that we have 1, 2, 3, 4, 5, 6 different subgroups. So make sure you're aware of that and how that works. What I want you to really do with this chart is just be aware of some of the drugs that work on some of the targets. As I said, I don't expect you to have it memorized, but is there something here that maybe you're familiar with? Have you been prescribed something before? And now you can see how that actually worked to clear your infection. So back to spectrum of activity. As we talked about earlier, we talked about broad spectrum versus narrow spectrum, and this is where we are again. So as you can see here, this is a chart that indicates how broad spectrum something is and how narrow spectrum something is. As you can see, tobramycin and Plixamin have very narrow spectrums. So if we know that you have a salmonella infection, then we can give you one of these drugs to treat that, and it's going to leave a majority of your microbiota alone because it's very specific for that bug. But If we don't know what's wrong and you're in critical care, then that's the case where we'd want to look at some of these broader spectrum drugs, such as look at the tetracyclines and how broad that spectrum is. And so that's what's important about that. So the key is to leave as much of our normal microbiota alone, but at the same time, kill off what's hurting us, because in the long run, that potentially could have more problems. Now, one more aspect of this target that we've been talking about with these is biofilms. And biofilms cause us a little bit of a heartburn, because what happens in biofilms is that the drugs that we know work against these microbes when they're not biofilms doesn't necessarily work on them when they are in biofilms. And we used to think it had a lot to do with the glycocalyx, but it's actually not true. They actually change their phenotypic expression when they are in these biofilms. And so that's what happened there. So we're working on new techniques, and we'll talk about that in topic 3 as to how to target these biofilms. But biofilms are a lot harder to treat than regular vegetative cells. So it's important to be aware of that. And we've been dancing around this subject all semester. We talked about it a lot, treating microbial infections. Now, your book goes into a lot of discussion about specific drugs and all the stuff that we can use for fungal, helminth, and protozoa infections. But what I really want you to take home from this slide is that these infections are just hard to treat because they can damage our organs a lot. So it's really important that we find specific agents that help us prevent the infection of these microbes, but don't damage our tissues too much. And so that's where we look for things, is anything that's slightly different from the other. And as I said, that's the big take home I want you to have on eukaryotic microbe infections, okay? And if I went over that too briefly, let me know, but that's the big take home. I figure you have enough information on the previous 11 slides already. All right, so our last slide in this topic is treating viral infections. Now, these are unique problems with viruses, right? Because viruses have almost no components to them, right? With this bacteria, we can target a variety of cell targets. We can do the cell wall, we can do the ribosomes, we can do the nucleic acids, we can do all that stuff. With viruses, we don't have those kind of targets. We have protein and we have nucleic acids, and that's it. So what we do instead is we have a few specific targets that we look at. The first one is we try to prevent the virus from entering the cell. Now, if you've ever heard someone tell you to take Zicam or zinc or anything like that, it's actually what this will do is it helps block the receptors on the cells so the virus can't enter the cell. And we have a couple stronger drugs that also do this. And so they either prevent that lock and key mechanism with the spike and cell receptor, or they prevent viral fusion to the cell membrane so they can't enter the cell. Our next target is the synthesis of nucleic acids, and by introducing analog nitrogenous bases that aren't real, it will actually prevent the replication of this DNA. And so that actually helps prevent the replication. If we can't do the replication, the virus can't spread. And then lastly, we can prevent the assembly and the release of the virus. And we do this through protease inhibitors. So protease is something that'll break down the proteins. So it kind of disrupts the protein so the shells can't be formed right and they can't be released from the cell. And so these are all different ways that we can treat these viral infections. But as you know, anytime you get a cold or the flu, mostly you just get prescribed bed rest because these drugs are still being worked on. We don't have super effective antiviral medications in this case. We have some for other ones, and this is why we try to use vaccines as preventative, because these are prevention with viruses is a lot easier than treatment. So this is the end of this topic lecture. As I said, there's a lot of information here, and this topic is a lot longer than the other ones have been. So let me know if you have any questions or if you want to go through this again in class. I'm definitely open to whatever it is to help you get those objectives.